Welcome everybody to another VITA Academy webinar. Today we have Mr. Peter Peasy. Hi Peter, how are you doing?
Hey Jim, how are you?
Good, good, excellent, excellent. So today we're going to have kind of a more of a unique, although it's not as glamorous per se as an interior, but the posterior nevertheless is very important for all of us to understand the function of it, how to design it, how to layer it, how to make it work in the patient's mouth and so forth. So today we're going to go over posterior design and function. And with that, Peter, I'm going to go ahead and let it off for you, and I'll get off. And if you want to start, we're good, and then I'll come back. Everyone, if you have a question, go ahead and write in the question box. Send in your questions at the end of the program. We'll go ahead and take your questions and answer them, and then we'll go from there. So, Peter, I'll let you take it away for today.
Thanks, Jim. And as usual, you threw me for a loop a little with this topic. Just so you know, I didn't realize what the topic was, and about 12:30 last night, I went on my email and looked at it and said, "Uh-oh." So I started trying to put together something to make it viable for you, and I hope I hit the direction. I think I might move it around a little bit, but I think what's important. So let's start with some of the basics. First off, posterior dentistry is extremely important, and I think I would argue that we don't talk enough about it in general. So it's a great topic, and I'm glad you kind of picked it. It made me kind of think of a few different angles and paths that I would want to go down to talk about it. You wrote in the description more posterior design and function and support, and I think I agree that that's kind of really the key aspects of what we're looking at and what we should be following more of. So it kind of made me start thinking about why we're not. And I went back and kind of revisited some posterior courses I did years ago. I want you to see what's on the screen here. This is actually an ad from sometime around 2005 or six, and I'm not sure what magazine it was in, mine or LMT. It doesn't really matter. But what's interesting is look at the ad, and I took out all the names and all the company information because I didn't really want you to focus on that. The focus of the ad was talking about what you see here on the screen, poor dentition, how the teeth were prepped either minimally or fully, and the beautiful restorative work at the end. And I think we saw a lot of this probably from the 90s up to about 2010, where our focus was so such on aesthetics and such on restorative. Somewhere around 2006, 7, and 8, that changed, right? And it changed for several reasons. I mean, one of the reasons is zirconia and alumina became products. And all the ads kind of started going in this direction, right? In the direction of being, um, these words kind of drove me crazy. Really fast, really tough, really easy. And the concept of the artistry really seemed to be taken away. And I always got a kick out of this ad specifically because if you notice here, these are some really poor looking PFM crowns. So this is nothing that we should have been proud of to start with. And the company was advertising how much better the zirconia crowns look. And I would argue those are pretty poor looking crowns too, right? So I feel like we got away from talking about the artistry and the passion and the things that are important for us and kind of jumped right into the fast speed. And today it's even worse, right? I think every time you open up a magazine or a paper, all you see is a scanner and a billion printed models, and we've kind of lost a little bit of a feel for that. So I find that a little frustrating, and I think your topic that you kind of threw at me, Jim, was a great one because times are changing, but I think it's a mistake to think that we shouldn't have the basic knowledge to fulfill the needs that our patients need. So this is a perfect example because I went back and I looked at one of the last posterior courses I did, and it was a simple single molar, and I went through an entire build-up process. And usually when I would build, or during these courses, I would build full contour, and the goal was to make the person kind of build everything up in one or two powders and get the real shapes and forms and all the things that were important, and then come back and do a little bit of a cut back to understand where the enamels went. And it was very similar to what I did in an anterior restoration. It was just a concept to build full, learn to cut back, and then kind of relayer the secondary components. Now, as the courses became more and more advanced, I stopped cutting them back and I would just build the dentin structures and then teach them to build the enamel structures. But interesting enough, just so you know, when technicians come into my office and are looking to work or wanted a job, I would sit them down and they would tell me, well, I've been a ceramist for 20 years. And I say, okay, here's what I'd love you to do. Build me the dentin on a single first molar. And they would kind of look at me like I was crazy because what they were used to was building a full crown and then grinding it into shape at the end. And I'm like, well, that's a problem, right? You need to understand what the dentin looks like before you can understand what the enamel, where the enamel goes and what the functional capabilities of it are. So the goal was to kind of figure out ways to teach those systems. And I think I spent a lot of time doing it, and I think hopefully a lot of people benefit from it. But let's be honest, times do change. And now that times are changing, not many people are building single molars anymore, although I still do. And by the way, not only do I still do it, boy, do I love when I come in and there's a molar on my desk because it's really enjoyable. It's one of the most fun things to still build. So I still build a lot of molars, although we still do monolithic zirconias and lithium silicates and many different materials. But in the end, we still do some layering on these. But I want to be honest and I want to be real in the sense that things are changing, and maybe people sitting there with a brush and powders isn't going to happen as much as it used to because the world has changed, and now I can mill those molars. I can go into my library and my CAD CAM machine, and I could put a design in, and I could put it into the model and make it look right, and actually start utilizing that. But there's some challenges there, right? Because no matter what material you're using, whether it was a VITA material or a different material, you have the same challenges. We could design in a green state. We could design in a fully milled restoration. We could design in wax for that matter. But in the end, I'd argue that our designs, as good as the libraries are lacking something. And part of that something might be just our knowledge or just our thought process about what a tooth should or shouldn't look like. Can we sell these molars? Yeah, you can. Can you sell them for as much as this one? I would argue no. And that's just a 3 or 4 powder buildup molar that not only looks a little bit better, but I would argue functions a little bit better. And that's where my real kind of a challenge, I think, comes into our profession today. So no matter what your method of getting there, whether it's lithium silicate or desilicate, if you're actually milling straight from the product or you're waxing and pressing, that understanding is almost secondary to the fact of all the other important attributes that come into play. And can I make lithium silicates and desilicates look a little better? Yeah, these are lithium silicates and desilicates. And I think you guys, most of you know that probably there's a slight difference between silicate and desilicates. Um, but the truth is, can I make them look as good as I can make a hand layered crown look? The answer is probably no. I think I can get closer today because the materials are better and better. But if I don't have the ability to understand the form and the function and the major importances of the anatomy, then I still have the same problem. And where the challenge that kind of comes in for me that I struggle with, and I actually have a student sitting with me today, is that we're teaching people the end result without teaching them the core, right? Of how you get to the end result. And that's problematic. And I think over the years, I've used this analogy and I'm going to use it again. Jen here in the lab, her brother became an architect years ago. And when he came out of school, he got his first job in a great firm here in New York. And he was excited to go in. And the day he went in, he walked into the office. They sat him down in front of a computer screen and they asked him to fill out his information. And his information was his name, his age, date of birth, social security number, all the normal stuff. And he sat there with that mouse in his hand, ready to start working. And the owner or the manager came over to him and said, okay, you good with the computer? And he said, yeah. And the guy said, okay, come with me. And he took him into a back room and he gave him a pencil on an easel and told him to start drawing. And I love that kind of thought process because I think that's what we're losing in our profession today. Digital is amazing. I have 3 scanners and 3 mills, and And socials here with me now is printing models already in 3 days, right? So it's fabulous. But that won't be enough. That won't be enough for the future if she or our future people don't get the understanding of what we're missing out on. So let me give you some examples of what I'm talking about. For me, when I'm designing something, I'm designing it to the form and the functionality of that particular patient. And I can't just be able to grab something from a library and pop it into a mouth and say that works perfectly. Because if I don't know the form and functionality, I'm in trouble. And I saw this phrase, actually, a dentist friend of mine sent this to me. This is a little extreme, but I'm going to kind of say it anyway because I think it's great. It says using AI to create art, design, or to promote your product or service may be an effective, cost-effective way of doing things, but it sends a clear psychological message. And that psychological message he wrote kind of harshly is your brand is soulless and you have no budget to really work with. Now that sounds extreme, right? But the last phrase is art by definition is human. It's a timeless truth that what we've created over the years. And once you made art scalable, it's not really art anymore. And I think that's part of the problem with single molar dentistry, right? It's become everybody wants to sell them as fast and as quickly and as we can, and we've lost it. And boy, I could tell you I've done lectures in 2006, 7, and 8 where I was like, we're making a mistake, right? We're showing people to jump from one to another without teaching them the cause and effect of what they do. And I think that's come to fruition because I would argue the molar is kind of bastardized today, right? Everybody's selling them fast and cheap, and it's not the market that it should be. I still build molars. I still do some monolithic, some micro-layered, some fully layered on all different materials. And I think it's important because that's what separates us from that market. And I want it to be viable from day one. And to be viable, people have to respect your brand. People have to want to wait in line for your brand. People have to want to pay more for your brand. And if your brand is the same as everybody else's, if you're taking that molar out of the library, popping it into a mouth on your digital model, and then staining and glazing it and sending it out the door without the thinking process, then you don't have viability. Doesn't mean you can't do those steps. You can and should do those steps because that's the market we have today. The difference is the only thing you could charge differently for is your brain, is your thought process, is your viability. And I love, I was in the city this weekend and I always joke and say, you can't walk by any of these stores without there being a line. There's a donut place in Manhattan on Spring Street that there's a line down the block every day and they pay $12 for a donut or a fancy pastry and you can't get in, right? Why? Because they're not selling Dunkin' Donuts. They're selling something different. And if they're selling something of value, people want the value, but we have to build that value. So there's a difference between us as laboratories being Target or Walmart or being Gucci or Yves Saint Laurent. And those differences really is our brain because the products are all very similar today. The machines are all very similar and the stains and glazes and ceramics that we put on them are all very similar. It's really about how we approach them that's going to matter. So whether it's AI or CAD, there is a flaw to me. And the flaw is these machineries take away our thinking process. And I want you to think because the thinking is what makes you valuable. Perfect example. Here's a 4-unit bridge. If I scan this and I put it into a digital world, well, I pick the material. And once I pick the zirconia will tell me the parameters of what I can and can't do. What do I mean by that? It'll say, well, you need to thicken up your connector here because the machinery knows it has to be 4 square millimeters. What it won't tell you is, oh, by the way, when you make that connector 4 square millimeters, you lost the ability to create an embrasure space, or you lost the ability to make the tooth in the proper position functionally. And that's our part, right? That's our job to be able to know and think through that, to understand what you can and can't do. And by the way, that particular last case or this case, they shouldn't have been zirconia cases to start with, right? This has to be metal ceramic. Why? Because I don't have the connector size to make a functional aesthetic restoration that fits to a human's mouth. The machinery won't tell me that. It'll only tell me the parameters of what I've programmed into the machinery. And this is where we have to step up. Another thing the machinery doesn't tell us is basics. And I can't tell you how many courses I've given over the years where I get so frustrated when I go into labs and I see how basics are lost. And by the way, I don't mean to sound mean to the CAD world because, again, I'm 3 scanners, 3 mills, right? I say it all the time. We're very digital here, but we're thinking in here. That's kind of our goal. And I can't tell you that I've been into many places where I have a ceramist or a designer or a wax up who's been doing this for 10, 20 years, and they keep telling me the same things that don't really make sense. Let me give you a perfect example of that. Mandibular teeth, posterior especially. When you look at mandibular teeth, they have a contact point, and that contact point is going to vary from the first bite to the second bite to the first molar to the second molar. Matter of fact, if you really look at the first molar as an example, notice how that fifth cusp actually protrudes into the contact of the second molar. Now, I get the pushback when I say that, and the lab technicians, the management, and even the doctors say, well, the doctors want big, flat, straight contacts. Okay, well, then your doctors don't understand function, because the bigger and the more broad your contact becomes, the less movement that tooth now has, the more food impaction can take place, and the more loss of the functionality that's going to be achieved by what you've just done by reinventing nature to fit your need. So when you make a first molar on a lower, it should have almost a C shape into the second molar. And my contact points are much more in the very center of the tooth. So there's kind of equal embrasures between the facial anatomy and the lingual anatomy where food can flow through, and every angle of this is made for mastication. When a patient chews and their food gets pushed away from their gum tissue, the angulation, the occlusal table, the contact point is all made to help that work. Now, I find lowers to be easier in the sense that more people get it. Where it gets more complicated for me is really more in the maxillary arch. So let me jump to the maxillary arch. And the maxillary arch is the interesting one because for years I've heard ceramists tell me, you know, when we do bridges in the upper, I make sure they design the contacts way back to the lingual so I have the ability to wrap my porcelain in and make it look nicer. And I just sit there and kind of snicker because I'm like, well, then you have no idea what anatomy looks like. Because if you really look at the upper arch, you're going to find that the contact positions on the upper arch are much smaller than the lower arch, and they're much more towards the buccal or the facial. The reasoning behind that is really simple. From a functional point of view, the lower teeth have the ability to move, right? The whole jaw moves around. The upper teeth is rigid. There's no movement on it. So the only way the upper teeth protect themselves from the lower teeth is being able to have wiggle room, is being able to actually move during the chewing and the mastication cycle. Why is that evident in what this picture shows you? Look at where your contacts are. Look at how small those contacts are. And that allows the tooth from a root position to actually have the ability to torque itself and to move itself as it's getting pressure from the lower tooth. So if I make this as a bridge, I get it, the teeth aren't going to torque anymore, especially if there's pontics, but I still have to design the functionality of the tooth the same. Look at the wideness of the buccal portion of the tooth and look at the narrowness of the lingual portion of the tooth, which is the functional area. So again, a computer's not showing you that, right? That's your knowledge. You can grab as many libraries as you want and put them into a model, but without the understanding of why you're doing it, you've really lost. Also, over the years, about 30% of the average clinical time is spent adjusting restorations. And now that we're in the CAD/CAM world, this number hasn't changed. Matter of fact, I might argue it's worse, right? Doctors usually get frustrated adjusting teeth. Well, now they're adjusting zirconia and lithium silicates and harder teeth. So it's a little more frustrating because if they have to make these adjustments, they're really working harder to make those adjustments, ruining more burrs and spending more chair time. So CAD hasn't fixed that. And I think that communication process for us becomes more critical. When we look at teeth, we have to understand what's right or wrong. And if we can't understand basics, like where the incised ledge belongs, what's the functional position of a cusp, then we don't have value. And for me, I want to make sure I have enough value to understand that there's nothing really more frustrating for the clinician to either have to be able to put restorations in and start modifying them either incisally or angle wise or occlusally. It's no different in the posterior end. So I want to make sure that no matter what we're doing, we're putting the right tooth into the environment that it belongs in, and we're not making the doctors spend all their chair time making all these changes and adjustments to what we're doing. So there is a functional relationship that needs to be understood. And I think we've spent a lot of years kind of defining that functional relationship. And it's funny because as much as we evolve, there are still basics. And I would argue that this photograph from, I think I took it in the Dawson Center in the early 2000s, is still probably one of the most relevant pictures that we should be looking at when we look at occlusal schemes. It's basically called dots and lines. And what does it really mean is when I'm working on posterior teeth, I'm really looking for centric stops or dots. I want to be able to hit my opposing arch, and whether that is on a marginal ridge or in a fossa, I want to make sure that I'm creating a dot where I'm actually hitting the opposing occlusal dentition. And that should be almost every posterior tooth, whether it's one dot, two dots, or three dots. That's argumentative. We can kind of have that conversation about you like to have three, you like to have one. But I would argue it's almost a silly point. As long as we have a centric stop that is not an aggressive stop, meaning that as I'm closing, I'm getting these big smudges and these big movements, well, then I'm getting too wide of an area. And intraorally, that's not going to play out the same way it works on your cast. So I have to think that through in my cast because remember, I just told you, especially the upper teeth, they're on ligaments. They have more movement to them. Your model does not. So when you're closing your articulator and pulling your shim stop through and you're getting a mark, it's not as accurate as what you're getting in the mouth because the mouth is going to have more pressure in those areas. So that's why in my lab, we try to really spend our time not only checking it from a basic point of view and opening and closing, but maybe squeezing those models together and kind of working through the friction aspects to make sure that we're not going to give the doctor back something that looks like this when they're done and they have to now harness it. So the dots in the posterior, the lines in the anterior are all about guidance, right? So every time the arch moves or slides to one side, you're discluding the posterior teeth and you're creating a freedom to not get the masseter muscle to trigger. So as I work through all my occlusal schemes, those are the things that I'm thinking through as I'm building up posterior teeth. I want to make sure that I'm getting my dots and lines. And if I'm not getting them in the right position, then I have to change that, right? So you can see that here on lower teeth, you see my functional dots. And I want to make sure if I actually have three dots here, right? Two cusp tips and a marginal ridge. I'm okay with that. I have one dot on a bicuspid. And maybe I'll have a graduated occlusion where I'll only get one or two dots on that second molar because I don't want it to be hitting closer to the center of rotation, which is my condylar position. And my job is to kind of work through that process that when it goes intraoral, not only do they look proper, but that they function proper. What's the sense of us taking a beautiful library and putting it on our printed model or hand building a beautiful anatomy if in the end, when the doctor puts it in the mouth, they're going to grind it out? And that is the fetus to us, and also it doesn't create our value. So one of the things that causes the biggest problem here for that is our understanding of what I call arc of closure. And the challenge here is that I think we're, again, this is not in a CAD program, this is in your brain and your ability to understand. When a patient closes their lower jaw, there is a certain arc that it closes under. And most of these semi-adjustable articulators that we use today are designed to work in that arc of closure. It's very similar to the jaw. Problem is, how many of the labs that I walk into actually still use semi-adjustable articulators? I would argue very few of them today. And even in my lab, although I use them, do we use them for single molar dentistry? No, usually not. We're using these little hinge access articulators. But I want you to notice something really important here. This would be the arc of rotation in a human's head, right? It's where the under the auditory meatus, it's their center point of rotation in the joint. And on the articulator, you can see where that is. When you come down here to my new center point of rotation on one of these little plastic articulators, that changes how the teeth function. So if I open and close the articulator from that point, I get a certain opening and closing. And you could do it from the upper or lower. Obviously, the lower is the tooth that are closing, but since we work, we usually kind of open the upper member of the articulator. But watch what happens when I show you the center of rotation from a real instrument or from the human. Look at how much different that arc becomes. So a lot of times when you're working through things on the articulator, you're really missing some of the key points. And this is a huge deal when it comes to something as simple as a molar. On a little rotational center, it looks like you're falling right into that fossa and everything's good. You put it in the mouth and you're wondering why the doctor's calling you and screaming, saying, I don't understand, I ground for 15 minutes and now your anatomy's gone, I need you to reglaze it or refire or restain. And that's really all because you're not thinking through the arc of how the molar works. So years ago, and I had to go back to some old lectures to find this. I guess I should make a better looking updated version of it right now, because boy, that looks pretty old, but I had to go back and find it about 1 o'clock this morning, Jim. Something I had done when I was working through teaching posterior anatomy. So when you look at a simple molar, whether it's upper or lower, I told you that for me, there are usually 2 or 3 centric stops, right? And those are basically where I want the opposing arch to stop into or hit. Sometimes they're in a fossa, sometimes they're on a marginal ridge. To be honest with you today, I'm more a fan of marginal ridge contact. Unless the anatomy is slightly shallow, then I'm okay with more of a deeper fossa. Obviously, deeper fossas look so much nicer, we get so much more detail into them. But depending on the occlusal scheme, it doesn't always work as well as we'd like to. After the centric stops, we have our functional cusp tips. So you'll see here that this is our function, this is our function. These are what is opposing into these lower, these red dots that you see here. Do I need to have all 3 cusp tips hitting into one of these? No, I'm okay with one centric stop, but I get it. Some people like 2, some people like 3, and that's just different thoughts on your occlusal schemes. Also, there's these non-functional cusp tips, otherwise known as interferences. And these are the cusp tips that you want to make sure that as you're closing, anytime you see marks or dots on the lingual of a lower first molar or the facial of an upper first molar, those are problematic. That means that you're going to be causing interferences in the occlusal functioning of your restoration, and those need to go away, even if it sacrifices the beauty of that crown that you just made, right? So it's more important that the functionality is correct. And from there, we went into the movements, some protrusive and lateral movements, and I won't define that too much because I think this gets a little hairy for what we're going today. It's more of an occlusal lecture, but in general, the point I'm making is these are the things that need to be in your brain when you're designing a restoration, right? And I can kind of keep going through this and say a working pathway, the non-working pathway. What are the areas of challenges where we have balancing contacts and non-balancing contacts more important in denture work these days, although I treat crown and bridge and denture work very similar. And then our protrusive movements and our surtrusive movements, we can kind of work through all of that. Rather than kind of give you an entire occlusal lesson, I'm going to say that what I'm really more concerned with is after my centric stop positions, I want to make sure that these areas are not causing problems. I want to make sure that as I'm moving through that cusp tip, that I'm not hitting other areas that become basic interferences and cause more challenges for us in the restorative process. And again, your CAD program isn't telling you that. They're only showing you the marks that are under more pressure and the marks that are under less pressure. You're going to get that feel in moving the arches around. And you can do some of that in digital world. I'm not going to say you're not. But the value of moving it in digital world is only valuable to you if you understand what the digital world is showing you. So again, it goes back to the pencil and the drawing board rather than just diving in. The goal is to be able to think of the mastication process and how the patient is opening and closing and how the teeth are coming together as they work through the occlusal schemes. And your simple anatomy on a molar is what does that. Here's another pet peeve, and this is one that kind of really bothers me, besides for contact position. I'll ask this group of people, and you can't answer now, so you don't have to raise your hands, but I always ask the question: what is the widest occlusal table in the mouth? And just so you guys are clear, the occlusal table is the point from here to the lingual cusp. And usually the answer I get is a lower first molar, an upper first molar. And once I start to hear that answer, I see the thinking about it, my brain immediately goes to, you don't really understand occlusal anatomy. And the reason it's so critical is because what tends to happen is we start thinking that because a tooth has a certain form to it, that the whole tooth has that form, and it doesn't. The actual occlusal anatomy or the occlusal table isn't defined by the emergence profile and the width of the tooth. That is defined differently. That is really defined by the planes. And I know when we talk about the planes in anterior teeth, I think everybody kind of grabs that, right? There is a first plane that goes into the gingiva. There's that middle third plane. There's that incisal plane. And you see those three angles. I don't see anybody ever talk about that posteriorly, yet it exists. It's exactly the same. You have the exact same into the cervical area. You have that middle third area that keeps your cheek away from your chewing table, and then that angulation of where the cusp tip goes into its opposing fossa. So just like anterior teeth, posterior teeth have the same planes. So when I ask you what the width of the occlusal table is, the answer that I'm looking for is that if you really understand the occlusal table, you'll understand that they're all exactly the same, that there isn't one wider than the other. Each occlusal table actually has the same amount of space from line to line, no matter if it's a bicuspid, a first molar, a second molar. Sometimes wisdom teeth might be a little bit different. But in general, that's the occlusal table. Everything else you see is the functional aspect of the tooth, and that is there for mastication and food diversion. One of the biggest challenges I see, not only on our end in the laboratory, but clinically, is a lot of the doctors aren't aware of this. I can't tell you how many times I just grabbed this out of my text. I just sent that to a doctor a few days ago. He asked me how his prep was. I said, your prep is wonderful. Look at all the nice detail. Look how clean your margin is. Look at the cord pack. But what did you miss? You missed the occlusal table. Look at the occlusal table here, and look at the occlusal table on this prep. And by the way, that line is generous because it's really a little bit more over here, right? What does that mean? How do I take that prep that has the exact same occlusal table as the opposing teeth and get my cusp tips to go into that position? I almost can't. And what's going to happen is functionally, I'm going to have a problem here because I can't get my cusp tip where it is because the prep didn't finish in the right position. So your knowledge of that is going to help your partners be able to show them. And I've taken this picture 1,000 times over the years. I could show you so many of them in my text because when they go to posterior teeth, they tend to think about making nice walls and having a retentive form. They're not thinking of the aesthetics or the functionality like they are when they're prepping an anterior tooth. And they're thinking, oh, I got to roll that incisal edge, otherwise my tooth is going to be out too far in the arch. Well, this is worse because without rolling that third plane on the tip of your molar, functionally, now I need a stronger material, otherwise the material is going to break. So that's where I kind of get a little antsy with how we're teaching this today without really teaching the core. And I can tell you I've been doing this kind of the same way for a lot of years, right? So even on crazy implant cases like this, I'm thinking of the posterior function more than I'm thinking of the anterior. This was an old case. I think I did this with Stephen Chu, if I'm not mistaken, this case a long time ago. It was a one-piece, heavy frame, right, back in the day. Today we break those up a lot more. But I want you to notice what I did here. As I was working through, one of the things that we came up with is making sure that we understand the incisal envelope and where I wanted to make those lower teeth finish. And once I understood that, then the posterior teeth became easier for me. What do I mean by that? Once I understand where the posterior teeth are, I don't want the doctor to be spending time adjusting them. So I'm going to use this anterior stop as my reference point for where the occlusion should be. And I'm going to make sure that when I finish the posterior teeth, I'm lightly hitting here. And then I'm going to take that away and change the envelope. So I have posterior function first and then anterior function. And even back in the day, I was kind of really working through that process to make sure that I'm getting my cusp tip where I want it, whether that's a marginal ridge or into a fossa. But I'm designing it in a way that I want to make sure that I'm capturing all the information based on the envelope, not just building posterior teeth willy-nilly and not thinking through the occlusal scheme. So as I'm building this, notice I built all the posterior teeth first. And I'm actually really trying to make sure that I'm going to come back and do my little correction bay and make sure that I'm getting just what I want. And what is that? My dots. A dot, a dot, a dot. And if I can't capture that dot, then I'm never going to be able to make this work aesthetically from an anterior position. I want to get that bilaterally balanced occlusion. I know that's a term we use a lot in denture, but to me, denture and crown and bridge are almost the same thing today. I think we define them too much and act like one's so much different than the other. No, I want bilaterally balanced occlusions. I want equal simultaneous contact. I want some sort of an anterior guidance, and I say some sort of hesitantly because I can argue that occlusally anterior guidance doesn't really exist the way we think it does, but I still want to have that anterior guided restorative posterior, and I still want my balanced occlusion in the posterior. So notice my little dots here, and they're a little too smudgy for me. So what am I going to do? I'm going to start harnessing in those dots as I work through the process. Too much. And if I see this, I know right away, interference. Those all have to go. So I'm going to flatten out those cusps. I'm going to change those angles. I'm going to keep redefining this until I get nothing but a dot in my occlusal scheme. And then when I have it, I can polish up and finish. So yes, I think like a denture across the board, even in crown and bridge world. What does think like a denture mean? Really simple. IEP. Where do the teeth belong in the patient's face? I feel like I've taught this 8,000 times in the last bunch of webinars. So I don't want to keep going through some of the older things, but every case starts the same. Where do the teeth belong in the face? Once I understand where the incisal edge is, now I have the ability to control my horizontal plane, control my gingival position, what's the length of an average central, and all of that is aesthetic. Those are steps 1 and 2 for me all the time. But the next step is the most critical, and that's the third position is now where is the occlusal vertical dimension? Where do the lower teeth belong underneath that aesthetic plane that we just created in the upper? And for me, that's about the lower incisal edge position, and then of course, the bilaterally balanced posterior teeth. So maybe in some ways we should be reversing that, right? It should be about the posterior teeth first and then the anterior. I guess I kind of think of it that way, right? I want that bilateral balance. I want that simultaneous contact. And I want to make sure that I'm not affecting the envelope as I'm closing my arches. So it's kind of the same for me over and over again. And in these crazy complex cases, you know, this case is presented as an aesthetic case. It's an old case, so please forgive the photography. It's not mine. It's a pretty old case. But the point of it is you know, right away, I can look at a case like this and say, okay, we're changing the OVD, right? We're gonna have to get away from all the functional wear that this patient has gone through. And the only way you're gonna really fix that is by changing the position of the teeth. But in order for you to change them, I can't just go into my CAD system, pull out a library, pick beautiful anatomy, and pop it in, mill them out, and put them in the mouth, and think that'll all work without the cause and effect of what those teeth need to do for me. So obviously I'm going to open vertical, and I'm going to go through all my normal steps, whether you're using a Facebook or a Cois analyzer. I'm more in the Cois world, but the goal is kind of the same for me. It's to think of it, how it functions with the patient and how it functions through their arc of closure. And everything is denture for me. So where do the teeth belong in his face? You can see we added composite to put that back to where we think they belong. And that's my incisal edge position. I go through all those same steps, incisal edge, where is the horizontal plane, where is the gingival, where will my OVD be and my envelope of function, and then lastly, my balance plane, right? And I'm kind of thinking through all of that. We'll provisionalize the patient, transfer that new provisional with another analyzer or another Facebook. So I'm making sure that everything I'm seeing is level on my articulator. And then I can come back, and this was one of my first digital cases all these years ago, back in 2008 or 9. So you can even see the old digital programs, right? How funny they look. But in the end, I'm going to restore the whole upper arch, some implants in there, some crazy implants in the anterior that I thought were awkward. But really, what am I trying to achieve? I'm trying to achieve a functionality so that when the patient smiles, the anterior looks proper, but more importantly, the posterior works, right? They have the right posterior anatomy and functionality that they need to function. And by the way, this case is probably, 15 years old now, right? And as far as I know, it's still in the mouth and all good. And I'll knock on wood so I don't get a phone call tomorrow that the patient broke a tooth, because that's usually what happens when I say that. And that's kind of the way it works for me across the board, right? So I want to make sure all the cases that I work through, as much as I think of them from the anterior, I'm really thinking them from the posterior, right? So if you look at Ella, and actually I just showed this case at Rutgers University last week. Um, if you look at Ella, I'm thinking denture, where do the teeth belong in her face? How much longer do I want to make the incisal edge position? And then how am I going to handle that functionally in the posterior anatomy, right? And also I always say, you can see right in the eyes of the patient when they're happy and when they're not happy. And I think it's important for us to kind of look at that and say, okay, if I was setting a denture, where would I put the teeth? How much longer do I want that incisal edge to be? 1 millimeter, 2 millimeters? And once I understand that, then everything triggers to me about occlusal scheme. What should those posterior teeth look like? What should my molar look like? What is the shape of that bicuspid that's going to work in this patient's occlusal scheme to support their aesthetic parameters, just like denture? Okay, so most of you have seen this case before. I won't go all the way through it, but I'll just give you the kind of basics. We do the same thing over and over again. We're using an analyzer rather than a face bow. I'm not opposed to face bows. I would just argue that there are some challenges to the face bows in the sense that the angulation that it creates on the articulator sometimes throws you for a little bit of a loop. So when I use a normal face bow, you'll notice that the angulation of the model is kind of very slanted. But if you actually look at the patient's face, the occlusal table is not that slanted. So if I follow the face bow, the problem that I have is I can change the arc of closure that I just showed you before, and some of those cuspal positions might not be as accurate as I'd like them to be. So we've kind of gotten away from the face bow world, and we've stayed more in the dental facial analyzer or Coit's analyzer. Why? Because that's going to give me a much more accurate plane, and it's going to give me a much more accurate opening and closing to manage my occlusal schemes. Another advantage it gives me is I can understand where to put the teeth. So as an example, for Ella's case, I knew I wanted to make the teeth 2 millimeters longer in the anterior. So what did I do? I took the table that's set to a horizontal, I dropped it down 2 millimeters, and then I waxed my teeth to it. I should say Jen waxed the teeth to it, because Jen does a majority of all the waxing in here these days. And I'm sure if she saw that wax up now, 8 years later, she'd say, oh, I could do it so much better, right? That's kind of the way we're always looking at what we're doing and trying to change and grow in the end. So once I understand where I'm going, now it becomes a little bit more about the functionality. We'll test this in the patient's mouth to make sure we like what we see aesthetically, and just look at the patient's kind of smiling there. So right away, okay, this is going to work. And now we just have to make sure that we can manage it functionally. And everything was done as single units. This was 28 single units. Her tissue was a little beat up. She had some tissue surgeries, and I think she was going through some cancer treatments at the time also. But the occlusal scheme worked out for us. In this case, has been in the mouth now for probably about 7 years. So far, again, I'll knock on some wood, no breakage or chipping. And she's a wonderful lady. And in the end, this can't work without the posterior support. So I appreciate all the digital information, and I appreciate all the libraries and the beautiful anatomies and all the things that we have. But I would argue they're not enough without you having some basic understandings of where that comes from. And a perfect example, Social's sitting here next to me. You guys can't see her, she's off camera. But she's dancing and jumping up and down like crazy. The point of it is that I know Shane's in the back probably watching too. We couldn't all squeeze in the office. The point of it is that the goal is really to understand. And I think the reason I brought her into the mix was because since she's been here, she's probably spent most of her time grabbing a spatula and trying to wax. And that's how Jen started and Kian started. Everybody here kind of started because that's where the foundation will come from. That'll make your transformation into the digital world or into monolithic world or a layered world so much better if you can really have that understanding of the form and the functionality. And that's where, excuse me, where you'll benefit the most with your patients, right? Where you can really change the lives of your patients and create all the things that you want and the value that you want. So, Jim, I hope I fulfilled your posterior um, lecture that you threw at me today. And I say throw at me, my fault that I read them last minute, but I hope I fulfilled what you asked me to do, and I hope there was some value for everybody else. And if there's any questions, I will gladly stay and answer them. I think I was pretty good. Oh, pretty good on time. Look at that. I nailed 50 minutes.
No, yeah, it's perfect. No, I think it covered a lot of good information. I really like the in a weird sense, you brought in pictures to show where the if you think denture, it really all comes together, and I think that's an important point that you always bring up. You know, think pink and white um, to get the right incisal length and figure out where that occlusal plane should be and what you're doing, an overall treatment plan, which is great. We do have a couple questions on AI come into play in the dental technology. What is your opinion on the AI coming into the technology?
I think I was pretty clear. Listen, I think AI is going to help us in so many things, and digital world in general help us in a million things. So I'm open to the help, and I preference it with I have three of everything upstairs: CADs, printing, milling, and okay. But we still have to know how to think. And the more we give over the thinking, the worse it'll be for you as a business owner or a technician 10 years down the road. So I think I warned people in 2007, 8, and 9 that don't become McDonald's and make Molars and sell them as quick as you can. And I think the labs that aren't with us today or that struggle the most didn't listen, right? And the ones that are viable are the ones that have a lot more knowledge. So AI is great, technology is great, but it doesn't stop you from being better. You need to kind of work your way around it.
All right. Now the question is on your centric points, on your contacts, are they point contacts? Are they a little bit broader? Or is there any kind of just a contact, longer contacts?
You want as little of contact as you can. You want a point. So dots and lines has been in my head since Pete Dawson drummed it in all those years ago. Dots and lines. I want dots in my contact. Anything bigger than a dot in the mouth will translate to a big table of occlusion that you don't want. So on your model specifically, dots and lines, keep them as small and pinpoint as possible.
And kind of a follow up, you want them all, of course, to equally come into centric at the same time, or no?
Yeah, yes and no. So there's something that I don't know if it's a fair term. I think I kind of coined it, but maybe I'm wrong. Maybe I stole it from somebody. I call it graduated occlusion. And what I mean by that is the closer you are to the central rotation center, the lighter I want the contact to be. So if I have a second molar, I don't want that hitting as intensely as my second bicuspid would hit. I kind of like the majority of my head to be second bicuspid and first molar. And then when I go more and more posterior, I'd like to get a little more lighter in the contact, only because the intrusion of the teeth, as you're closing in, the teeth intrude a little bit into the periodontal ligament. What takes the most effect on that, or the most wear, will be those posterior teeth because they're hitting closer, because they're closer to the center of rotation.
All right. And then when you think denture, um, some people have been used to using face bows. Would you recommend facial analyzers for denturists too, as well, if that's
100%.
possible?
Facial analyzer across the board. And by the way, if you're not using a face bow or a facial analyzer in denture, you're making a huge mistake. But I think the facial analyzer is really the best tool we have today for communication, aesthetic planes, and functionality.
All right. And then that pretty much wraps up all the questions. If anybody does have any, go
I'm
ahead.
just going to add with the face blow and the analyzer, just to be clear. When I used to buy face blows, they were $2,000 each, and the articulator was a fortune. A facial analyzer is like 200 and something dollars. It's a joke. I could tell you in the beginning when I started using, I just bought a few for my doctors and gave them to them because I wanted them to use those more than face blows. So the larger labs, it should be kind of their protocol is getting them in there. Sorry to cut you off. I just wanted to add that in.
No, 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 it's fine. It's your message is important for everyone, and you've got a vast amount of experience, and through all the training you've had, we greatly appreciate you delivering all of these different topics from your perspective, which is nice. So, any other last comments you might have for the audience before we let everyone go?
Uh, no, I'm actually my brain is focused on the two posterior bridges on my desk that are due for 3:30 today. That I have to probably reglaze and get them over to the office as quick as possible. But besides for that, I know I have some dates coming up. I just got invited to speak at the NGS here in New York, and I think I'm in Canada next month, and maybe some other local dates around. But otherwise, if you have questions, you can always email. And then Jim, we have a team webinar coming up. I think I got to check the date on that.
Yeah, I'll have to look at that as well.
I'm not
Yes.
sure what that date is, but I'm going to be doing that with a dentist friend of mine from Ohio. His name is Dane. I never pronounce his last name the right way, but Dane's a fabulous clinician. I met him in school. He's been coming here ever since. Now he has his own practice in Ohio, him and his wife, and he'll be partnering with me on the next team webinar. So that'll be fun.
Yeah, so for some of you who didn't make it, Peter has actually, we do a couple webinars this year, which is different than we've done in the past. Um, Peter's been paired up with a dentist to kind of give you deliver a message of between the laboratory and the dentist and kind of get different perspective, which is really nice to hear. The give and take and the communication. So it'll be a really fantastic program. You can always catch us on the VITA North America website and look up, and you can find when that webinar is gonna occur. I don't have it right in front of me right this minute, but let's see. We have one more question. Yeah. Yeah. So, all right. Well, I want to thank everybody for joining us, and Peter, again, I appreciate taking time out. You get back to that work, back to those posteriors, and don't make any mistakes.
It was nice seeing you in Cali a few weeks ago, and I enjoyed it. It was nice having dinner with you and spending some time. So thank you for everything.
Yeah, it was good to see you too as well, and thanks for all your hard work. Appreciate it.
Take care, everybody.
That will end today's webinar. Thank you for attending.